Hello, my name is Louise. I'm a dementia support specialist from Dementia Australia, which means that my job is to provide education and support to people living with dementia, people concerned about their memory or cognitive changes, and their family and friends who are supporting them. So I'm joined by my colleague Jane, she's up at the table, who works in the Dementia Friendly Communities team. So her job is about making communities aware of what dementia is, because as I'll show you, it's on the rise, there is a lot of it around, and the community can do a lot to enable a person living with dementia to keep living a good life and to keep living it at home. So there's a lot of information in these slides. I will jump over a few, so don't panic. I'm still going to touch on the main pieces of information. We've also got a lot of information on the table, 2 sheets in particular that Jane will hand out at the end that summarise what I've talked about, so you can look back at it, so you don't need to be frantically taking notes. Okay? So I'm not going to touch on all these things, but I'm basically going to start by giving a little bit of an overview of dementia in terms of its prevalence. I'm going to talk about how a healthy brain works. And the reason I talk about how a healthy brain works is that if we understand that, we can understand what changes we see with a diseased brain and why we see them. Then I'm also going to talk about the different types of dementia, not every single one, because there are over 150 different types, but the 4 main types of dementia and how they differ, so the different symptoms that you see. And then I'm going to finally talk about what you do if you're concerned about yourself or somebody you know, what the process of diagnosis looks like, and what non-pharmacological supports are available out there, and particularly what's provided by Dementia Australia. So up front, I'm just going to let you know it's not a sales pitch. Dementia Australia is funded entirely by the National Dementia Support Programme, which means it's federally funded, and any services that we deliver are free of charge at the point of delivery, so you don't pay for any services from us. Any questions before I get started? Okay, so why is it important that we talk about dementia? It's important because there are, at the moment, this year, around about 420,000 people living with a diagnosis of dementia in Australia. That means there are probably significantly more that they just haven't yet got a formal diagnosis. Of that number, almost 29,000 are living with what we call younger onset dementia. So younger onset dementia is the same disease, but it happens to be diagnosed in a person under the age of 65. So most people think that dementia is an older person's disease. The risk of developing dementia does increase as you get older, but it is a pathological change in the brain, and it can happen to people as young as in their 30s and 40s, and even children. By 2054, it's estimated that more than 800,000 people in Australia will have a diagnosis of dementia. And there's a couple of reasons for that, and it's in a little bit like the cancer nurse said before. The process of diagnosis, the process of understanding the disease, is getting better all the time. So people are being diagnosed earlier or more accurately, and we have an aging population. So we're surviving more other diseases, heart disease, diabetes, cancer, and we know that the biggest risk factor for developing dementia is age. Of those 421,000 people living with a diagnosis now, there are approximately 1.6 million people involved in their care. So that's the people who are paid to care for them, but it's the spouses, the children, the extended family who provide support. So you can see why I want to talk about dementia, why we want to raise awareness and make the community aware, because it affects so many people. Okay, So moving on to how a brain works. Now, I'm not a doctor and I'm not a neurologist, so this is brain biology 101. We're looking at a schematic view of the brain. When we talk about the brain, we divide it into 4 lobes. And those 4 lobes are primarily responsible for particular functions. But as you will know, the brain is very complex. All those lobes have to work together in order for our brain to operate. But it helps if we divide it up and talk about the main things that they do, because it helps us understand the symptoms. So we're going to start with the frontal lobes. So the frontal lobe is the bit immediately behind your forehead. It's responsible for what we call executive function. So the ability to make plans, to organize ourselves, to make decisions. So it's what makes us different from the apes. It is responsible for us stopping and starting actions. So motivation, having the idea to begin a task, knowing when it's appropriate to stop. It's responsible for regulating our behavior. So that filter, when you're thinking something and you don't actually say it out loud, or how it's socially acceptable to behave. So for instance, putting on your clothes before you walk down the street, going in the bathroom when you need to go to the toilet, that kind of thing. It's responsible for our working memory, so what we need to know in the moment, generating speech, and importantly, insight. So a person with frontal lobe damage lacks insight into how they're behaving, into how they're presenting, into how other people are perceiving them. They typically think that the problem is somebody else, not them. Okay, so you can see that if somebody has damage or a disease in their frontal lobes, it will become difficult for them to make plans, to organize, to motivate themselves. They typically become quite apathetic. It will be difficult for them to regulate their behavior. It will be difficult for them to know what's socially acceptable in terms of how they're behaving, but also how they're talking. So maybe become very blunt and quite rude and selfish and inconsiderate of other people. And it can affect the way people speak. So their ability to choose words, to produce words, or to use the right word. Okay? Something to remember, I always find helps with a frontal lobe, and it might be because I have teenagers. A frontal lobe is not developed in a human, not fully developed until the age of 25. So when we talk about impulsive behavior in teenagers, it's because their frontal lobe isn't completely developed. Move that on to a person whose frontal lobe is damaged, and you can see why their behavior is going to change. Does that make sense to everybody? Okay, the temporal lobe is the part of your brain that's in your temples, so above your ears. There's 2 things going on when we hear. There's the ability to hear, which an audiologist is testing and maybe can correct with a hearing aid. And then there's the ability of the brain to understand what you're hearing. That's what the temporal lobe is doing. So the temporal lobe is processing the sound you hear. So let's say you hear a sound, but you don't see it. So we're sitting here and we hear an emergency vehicle go past with its siren going. The temporal lobe is telling us that's an emergency vehicle. That you're hopefully understanding the words I'm saying is because your temporal lobe is interpreting what I'm saying. Okay, so it's not the ability to hear, it's the ability to understand. Somebody with temporal lobe damage, so a disease that's in the temporal lobes, will lose the meaning of what's being said to them. So they'll hear the sound, they'll hear the words, but they won't understand them. Okay? Also quite common with temporal lobe damage is somebody who maybe learned English as a second language starts losing their ability to understand English, but can still understand their mother tongue. The brainstem, that controls the involuntary function, so things that are happening all the time without us thinking about it. So your heart beating, your breathing, your blood pressure, sleep coordination. And then we've got the parietal lobe, so that sits at the back of the head here. And the parietal lobe is responsible for what we call sensory processing. So sensory processing is the brain's ability to make sense of the information we're taking in through our senses. So our senses are bombarded with information all day long. You know, what we're seeing, what we're hearing, what we're smelling. The brain has to interpret that in order for us to function. Somebody with parietal lobe damage is not interpreting what they're seeing correctly or what they're hearing, or particularly maybe what they're feeling. So the touch in terms of whether something's hot or cold. For instance, putting a hand to pull a hot dish out of the oven and not feeling the heat, but finding their hands are burnt. That's parietal lobe damage. It's the ability to keep attention, so to focus on something, start a task and see it to completion. Okay? Not walk away halfway through and forget that you were partway through doing it. Or to pay attention to a conversation or a list of instructions. So, you know, you might say, oh, can you go to the bedroom and draw the curtains and make the bed and pick up your hat because we're going out? If you've got parietal lobe damage, it's way too many things to remember. You can maybe go to the bedroom and pick up your hat, but you might have forgotten to draw the curtains and make the bed. The parietal lobes are responsible for the ability to read and write, and specifically to interpret what you've read. So you might be reading the newspaper, but interpreting what the story is, or interpreting what you've written, is difficult if the parietal lobe is damaged. It's responsible for calculation. So by calculation, obviously, I mean mental arithmetic, but I also mean the ability to handle money, the ability to tell the time. So things we take for granted, as being able to work out how much change we're going to be given if we pay with a $10 note, for instance, that's parietal lobe. And what we call spatial orientation. So the ability to find your way in space. So that's to leave home and go for a walk and find your way back. That's the ability to drive down to town, know where you're going, and be able to drive home. And as dementia progresses, it's the ability to find your way around a house. So maybe from the bedroom to the bathroom, or from the living room to the bathroom, for instance. Then right at the back of the head, we have the occipital lobes. And the occipital lobes do for sight what the temporal lobes do for hearing. So again, when you're looking at something, your vision can be corrected by an optometrist by giving you glasses, for instance, or perhaps surgery for a cataract. But how your brain interprets what you see is a result of what the occipital lobes are doing. So somebody with occipital lobes will either see something differently, so their depth perception may be different, their ability to see change in tone of colour may be different, the placement of where something actually is. So I worked with a client whose husband had occipital lobe damage, and the way she first identified it was he was driving down the centre of two lanes. And when she said, can you put the car in the lane? He said, well, I am in the lane, because he saw the lane markings offset from where they actually were. But of course, what he saw was his reality. That's what occipital lobe damage is. An optometrist will tell you that your sight, your vision is fine, but it's the way the brain is interpreting what you're seeing. And then right in the center of the brain, and it doesn't look like this blue oval, is the limbic region. The limbic region is responsible for where our emotions and our memories are processed and formed. And a word that you will hear a lot connected with dementia, and in particular with Alzheimer's disease, is the hippocampus. Because the hippocampus is a very small part of the limbic region, and it's where the short-term memory starts, so where the process is coordinated. It's the place where Alzheimer's disease starts. Okay, so when you have disease attacking that part of the brain, that's why you get memory loss. Now, at the end, Jane will give you a sheet that gives you these diagrams and tells you all these things, so I don't expect you to remember them all. Does anybody have any questions about what I've shown? Okay, so when we talk about dementia, we use dementia as an umbrella term. So dementia is describing a set of symptoms that are caused by any number of brain diseases. So over 150 different diseases of the brain. But what they have in common is that they are all causing a gradual and progressive change in the way a person thinks and operates, such that they cannot operate safely independently. Okay, so as we age, everybody undergoes cognitive change. So long as you're operating independently, safely, that's what we call normal aging. It's where the changes are such that they impact the way you can look after yourself every day that we have cause for concern. It's important to know that no two people are affected the same way, because we're all individuals, our brains all work differently, our characters, our life experiences are all different. And also that it's not a normal part of aging. So we know the chance of having dementia increases with age, but not everybody who ages is going to get dementia. So at the age of 65, on average, 1 in 10 people have a dementia. At the age of 85, 3 in 10 people. That still means 70% of the population of 85-year-olds do not have dementia. Okay, so it's common, but it's not everybody. An analogy I often make in terms of that umbrella term is talking about a fruit bowl. So if you have a big bowl on your kitchen bench, and you call it the fruit bowl, inside your fruit bowl is an apple and an orange and a banana and a pear, whatever. So dementia is our fruit bowl. Inside that fruit bowl of dementia are all the different diseases. Okay, so I'm going to come on to those. Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies, all different diseases. Like your apple, your orange, your pear is all fruit. Does that make sense? You will often hear Alzheimer's disease and dementia used interchangeably. I've got Alzheimer's disease, I've got dementia, therefore I've got Alzheimer's disease. It's not the same thing. Dementia is that progressive loss of function, the change in the symptoms. Alzheimer's disease is the pathological change that's happening in the brain. So it's like the type of cancer. It's like saying I've got breast cancer, not I've got cancer. Okay? It's important because, as I'm going to show you, the different dementias have different symptoms. So it helps you understanding if you use the correct terminology. The reason they're often used interchangeably is that Alzheimer's disease is the most common form of dementia. It's the one most people know about. Most people who have dementia, 60% of people who have dementia have Alzheimer's disease. Is that clear? Anybody got any questions? So normally when you say to somebody, oh, what are the symptoms of dementia? Most people will tell you it's memory loss. Again, because Alzheimer's disease, the primary symptom is memory loss. So it's the one most people know about. But hopefully what you picked up from when I talked about the healthy brain is that dementia can also impact language. So the ability to speak and the ability to understand when somebody's speaking to you. It can impact comprehension. It can impact a person's judgment, so the things they choose to do, the way they choose to behave. Actions that are out of character, for instance, may be symptomatic of dementia. It can impact a person's ability to make plans, their spatial orientation, so their ability to find their way around, and also to know where your body is in space. So take, for instance, you're walking through a door frame and there's a problem with spatial orientation. You might not position your body in the center of that door frame. You might constantly banging into the side of it or banging into things because you think your body's somewhere else to where it actually is. And importantly, dementia can really impact a person's mood and personality. Okay, but we'll come on to that. Any other symptoms that people may have seen or may have been aware of? Just like me to go on and talk about the different types? Okay, so like I said, there are more than 150 different types of dementia. The four I'm going to concentrate on today are the four most common. So Alzheimer's disease, vascular dementia, Lewy body disease, and frontotemporal dementia. There is information on the sheet, the summary sheet that you'll get at the end about all of them. So this is what's going on with Alzheimer's disease. In the blue circle on the left, you can see a healthy brain cell. So that's your brain cell is the round bit, and then what we call the dendrites, the big long arms that come off it. And that's how brain cells communicate from one to another. So they send information from one brain cell down this dendrite, up another dendrite to the next brain cell. If you look on the right-hand side, you can see those white clumps of, it's called amyloid. It's a type of protein. So what happens with Alzheimer's disease is there's an accumulation of this amyloid into what we call plaques. They form these lumps, and they interrupt the messaging going from one brain cell to the other. Okay, so I often think about it a little bit like roadworks. So if you're driving down the street and there's a roadworks, you get a diversion and you can get to the same place, but it takes you a bit longer. So in the initial stages of Alzheimer's disease, you get that buildup of amyloid plaque, but we've got billions of brain cells. So the message can't get through one way, it picks another way and it goes round. Takes a little bit longer, but it gets there. But like if you were in town and they started digging up every road, it would get harder and harder to get through. As Alzheimer's disease progresses, you get more and more of these plaques building up, and there becomes less and less options for the brain to find the message, to find its way around the brain. Does that make sense? So you can see from the middle picture, and it shows you here as well, that what happens is as those plaques stop the flow of information around the brain shrinks. So on the left-hand side, you've got a slice through a normal brain. So you can see it's quite full of volume. It's quite puffed up. On the right-hand side, that's a brain that is affected by Alzheimer's disease. So you can see the brain has shrunk. So inside the skull, the whole brain has shrunk. The gaps are getting bigger. And if you look where the squares are, in particular down the bottom, you can see that memory and then also language, so the parts of the brain that are responsible in particular for memory, shrink the most as the brain cells die. That's why you're seeing memory loss as the symptom. And as the disease progresses, the brain shrinks more and more and has less and less function. Any questions about Alzheimer's disease? Vascular dementia refers to a type of dementia that is caused by an impact to the way oxygenated blood is circulating around the brain. So we know that our heart is pumping oxygenated blood around the body. It needs to provide blood to the brain to make it work. So the brain takes up about 2% of your body weight, but it uses 20% of your energy, so your blood flow that's going there. There are two ways that blood supply can be reduced to the brain. One is either through a blockage, so a thickening of the arteries or the other blood vessels, or a blood vessel in the brain can rupture and the blood can come out into the brain tissue and damage it. Typically, vascular dementia is caused by stroke. So that could be a large stroke that has a physical manifestation and you see paralysis of one side of the body. But more commonly, it's caused by a series of mini strokes or transischemic attacks, TIAs, that you don't even know you've had, or a person doesn't even know they've had. And the way they diagnose it is a brain scan will pick up those damages in the brain, the markers that have been caused by those attacks that you didn't know. It can progress over time if there are more vascular events. So when we talk about progression of Alzheimer's disease, we talk about a downward trend because those plaques are building up steadily and a person's function is gradually declining, like a hill. Vascular dementia is different because a person will plateau at a particular level and then a vascular event will happen and there will be a dramatic decrease in function. Right? They'll then plateau again at that same level until there's another vascular event and then another. So it's more of a stepwise decline. Symptoms vary. They vary because, go back to that picture of the different lobes of the brain, it depends where the vascular event occurs in the brain. So if the event happens in the occipital lobe, you're going to see difficulty with the way the brain is interpreting what it sees, but memory might be preserved. If the event happens in the frontal lobes, you're going to see all those changes in executive function and behavior, but memory might be preserved. Does that make sense? There can be an overlap with Alzheimer's disease, so it is reasonably common that a person will have both going on at the same time. That's what we call mixed dementia, where there's that Alzheimer's pathology, so the buildup of plaques, but there's also a change in blood flow to the brain, and that's vascular dementia. Okay, moving on to frontotemporal dementia. Frontotemporal dementia has become a lot more well known in the last year since Bruce Willis was diagnosed, and his family very bravely came out and told everybody what it was in a bid to increase awareness. There's two main types of frontotemporal dementia. So one is what we call behavioral variant, which affects the way a person behaves. So this is really important because a person, their memory is operating as normal, right? But they change in the way they behave. They typically become more selfish, less empathetic. They become quite inflexible, quite fixated on doing a particular thing or behaving a particular way. They often lose inhibition. They've lost that filter as well, so that's social regulation. And so they start behaving differently. Now remember that when we talked about the frontal lobe, we talked about insight. A person with behavioral variant frontotemporal dementia, or FTD, doesn't know that they're behaving like that. They think that the problem is everybody else. They think that they're normal. As a result, this can be really difficult to diagnose, or it can take a very long time to diagnose because it's often the word of one person against another. Okay, it's often misdiagnosed, particularly as depression, because it's a change in behavior that can mimic, like you can often see the same in depression. The other variant is a language variant, and this is how Bruce Willis's dementia started. So with difficulty finding particular words. Now that doesn't mean if you forget a word or the word's on the tip of your tongue and you can't quite get it out that you've got FTD. You haven't. This is progressive difficulty finding words, or using the wrong word, or not understanding the word that you're hearing or using. But it can also be difficulty producing speech. And that can manifest in two ways too. It can manifest in a person uses a lot of words, but they don't make sense. It's just a random collection of words that mean nothing. Or it can be that the speech really slows down and it's very difficult to produce the words. So there's a lot of different ways this can present. Any questions about FTD? It tends to be diagnosed in younger people, so people in their late 50s and 60s, but it is diagnosed in older people too. And then the other main form or most common type of dementia is called Lewy body disease. Now, Robin Williams, remember the actor? He had Lewy body disease. I think his wife did a fair bit of raising awareness after his death as well. Lewy body disease is also caused by an unusual buildup of a protein. It occurs in the center of the brain cell, so you can see here that little blue blob. That's a Lewy body. It's called a Lewy body after Dr. Lewy, who identified it. Lewy body disease is is characterized by fluctuating cognition. So a person can present as completely normal, and then over a timescale of minutes or hours or days can be very, very confused, and then can go back to completely normal. So it's difficult. You can see it's difficult. It's also characterized by visual hallucinations. And for reasons we don't know, those hallucinations usually involve small animals and people, particularly children. As a rule of thumb, they're not threatening. So a person will be seeing something that isn't there, but they're not frightened by it, but they may be engaging with them. So they'll be talking about the rabbits that are running around the living room or the person who's in the house. And they're not there, but they're very, very real to the person. And it's really important to know that you can't dissuade them because that's what their brain is interpreting. Okay. Lewy body disease is what we call a spectrum disease with Parkinson's disease. So it's the same pathology, but it's a different part of the brain that's affected. So Parkinson's disease, as you probably know, starts with the physical changes, so the rigidity, the tremor, the slowness of speech, the slowness in movement. Not everybody, but a number of people who have Parkinson's disease will go on to develop either Parkinson's type dementia or Lewy body dementia, because it's the same pathology, just in different parts of the brain. Equally, people with Lewy body disease, not always, but often will go on to develop Parkinsonian type symptoms. Generally not the tremor, but often the change in movement, so the shuffling or the rigidity or the increased risk of falling, that kind of thing. There's a lot of people with Lewy body disease, because of that fluctuating cognition, also present with depression, so about 40% of people. Depression and those hallucinations can be treated by medication, but Lewy body disease is particularly sensitive to different types of medication. So they don't always make it better. They sometimes can make it worse. It's not a genetic type of dementia, generally. Most dementias are not genetic. There is some familial Alzheimer's disease, but it's in about 2% of cases, where you have instances of dementia within the family. So, for instance, my uncle has Alzheimer's disease, my grandma had Alzheimer's disease. It's because there are so many people who have Alzheimer's disease. It's not because he had it because his mother had it. Does that make sense? The familial types of dementia tend to be the ones that are diagnosed earlier, so 40s, 50s, not the ones that are diagnosed as people get older. Any questions about the four main types of dementia?
My mum's got macular degeneration very badly, and I know Deb's mum has as well. And they can get something as they age with their loss of sight. They can get something called Charles-Bonnet syndrome, which presents exactly the way as those hallucinations you're talking about. So it's not dementia, it's to do with their sight. Mm-hmm. And apparently what happens is when they're lacking in their sight, their brain is making up all these other things. So can you explain the difference, or is it specific? Like if they don't have a sight issue, would that mean that it's dementia?
Great question, and a very nice interlude to what's coming next. It's as if I planted you in the audience, see. So hopefully this will kind of answer your question. Dementia is what we call a last stage diagnosis. There are lots and lots of different diseases or different changes in health that mimic the symptoms of dementia. So the example you just gave is one. Depression, anxiety. Depression can make a person apathetic, can change their eating habits, can change the way they behave. Anxiety, the same thing. Sensory problems, so the example you gave in terms of sight, but also a person who's hard of hearing. They may appear like they're not understanding what you're saying. They may actually not be hearing what you're saying. I'm sure I'm not the only person who's experienced that. Lots of different disorders. So change in thyroid levels can cause confusion. Diabetes, if your sugar levels are not controlled, can cause changes in cognitive function. Malnutrition, so somebody who's not eating properly. Dehydration. Dehydration is a huge issue, because dehydration will often, particularly in residential aged care, will lead to a urinary tract infection. Infection changes the way a person thinks and causes confusion. Some kind of trauma, pain. If you're really experiencing a lot of pain, particularly if you can't verbalize it and have relief from medication, will affect the way that you present, the way you talk, the way you behave. Fatigue, delirium is a huge one. Delirium is very different from dementia in that you have a very sudden onset of symptoms, so very sudden memory loss, confusion, change in behavior. Side effects of medication and grief. You'll know that if you're grieving for somebody, you don't think as clearly. The important thing about this is everything on there can be addressed by a doctor. Okay? So we can treat dehydration, we can treat delirium, we can treat changes in hormone levels, right? And you will then see a recovery in cognitive function. So often we hear that people don't want to go to the doctor. They don't want to say, I've noticed I'm forgetting things, or I've noticed I'm not thinking as clearly, because they're worried that they're going to get a diagnosis of dementia. A large number of people who go to the doctor have something else, and you can get a script and you can recover function. Okay, so my number one message is that if there's any concern, is address it, because it might not be. So I'm going to skip ahead a whole lot of slides now so we can talk about, if you have concerns, what you do. Okay, so the first thing we're going to do with concerns that we have about ourselves, or in particular people we're caring for, is visit the GP. Now, we've talked about how change in the way a person has insight into their behaviour may mean that they don't think there's anything wrong and therefore they shouldn't go. At that point, I would encourage you, as the carer, to have a word with your GP and get it checked out in another way. as part of a general health check. Okay? A GP can do a thorough assessment in terms of a blood test, urine test, for instance, to rule out all those other things. They can also do a sort of screening in terms of cognitive ability. It's what they call a mini-mental. So they ask a series of questions. If they rule out everything else, they will then come to what's called a probable diagnosis, and they'll refer people on to a geriatrician or a neurologist or a memory clinic. What I always stress is that in that GP appointment, or in that appointment you're with a specialist, you have a finite period of time. And often, a person's function can change, and they can present quite well in a particular situation when they're not presenting that well the other 23 hours of the day. So, where I say here, take a list of your current concerns. If you're accompanying someone to the doctor or suggesting they go, you might want to take with you a list of examples of things that have changed, or things that aren't the way they used to be. And I suggest you write them down because A, they'll probably be a lot, but also you don't want to be on the spot in your 10-minute appointment to get all that information, recall all that information. So when a person is referred on to a geriatrician or a neurologist, they will start with the blood tests and the urine tests. They'll start with a detailed medical history of a person, but also of their family, and that's to rule out all the other things. There will be a physical examination. There will be a series of cognitive tests, and then a best case diagnosis is made by some type of brain scan, because that's where you can see the little marks on the brain scan. If you've had a series of small strokes, for instance, you might be able to see the shrinkage of particular areas of the brain, which will indicate what type of disease it is. You will often hear that a definitive diagnosis can't be made until autopsy. It's true, but they have got a lot of information that they can use, but also explains why your evidence is so important. Okay? Does that make sense? So hopefully what I've covered is an overview of dementia in terms of it is a progressive disease, it is a terminal disease, and there is no cure. Now, often we will hear that people have been to a specialist or been to a doctor and they've said, well, there's nothing you can do, just go home and put your affairs in order. At Dementia Australia, we work really, really hard to educate people that you can live well with dementia. That yes, there are cognitive changes, but with the appropriate supports in place, people can live meaningful, happy, and long lives despite the disease. In most cases, it isn't inherited, so because your parents had it, doesn't mean you're going to get it. The risk, or vice versa, the risk does increase with age. The symptoms are different depending on where the disease is in the brain, but also the experience is different. So two ladies of the same age living in the same town with Alzheimer's disease will experience it extremely differently, because it will depend on their life history. So you make sense of what's happening to you by what's happened to you in the past. Your mindset, how you approach it, the supports that you have around you, the way people treat you, which is why we can all learn as a community how to behave better around people with dementia. We can make a real difference to the way people experience their disease by informing ourselves and changing our behavior. Early diagnosis, early investigation by your doctor is the best thing you can do, because you might be treating something that isn't dementia, or you might have early access to drugs that may delay the progression of the disease. So there are drugs for Alzheimer's disease. They don't cure it, but they do delay the progression. Okay? but they work in the early stages. They don't work if you rock up and you're several years into the disease. Just before we come on to questions, as I said at the beginning, Dementia Australia is funded by the National Dementia Support Programme. We are based in Perth, but from Perth we do support the whole of WA. We do a lot of work with people by phone and by video call. We do one-on-one support with a dementia support specialist. So that's talking about your personal situation, what it is that's difficult, what strategies, what education can we give you to improve life for the person with dementia and the people who are caring for them. We have 3 dementia-specific counsellors in the office in Perth. So they deal more with the emotional side of it, but their knowledge of dementia is such that they inform their practice through that. We have some support groups, and I know this afternoon we're going to talk about creating a support group in person here, but we also have some that are online. We have an abundance of information and resources. There's a lot on our table. We carried it all the way down from Perth, so please take it because I don't want to carry it all the way back. There's a lot of information on our website. We have a helpline that is open 24 hours a day, 7 days a week. You will speak to a dementia advisor right there and then. And all our information is backed by science and lived experience. So you will know that you can get on Google and you can find out all sorts of things. The miracle supplement you could be taking, or the miracle change in diet, or whatever. It's really important that whatever information you access is backed by science and it's authentic. So Dementia Australia and Alzheimer's WA as well pride themselves on providing information that is accurate. So that's just a sort of plug to be aware of where you're picking up information. And finally, Dementia Australia do a lot of advocacy work. So we have advocates who are people who've engaged in our services, either living with dementia or caring or have cared for somebody. But you'll see they're lobbying the government for changes in services, for the changes in the way communities are presented and things are understood. So we like to say that what we're doing is enabling people to live well, so that message, go home and get your affairs in order, is not one that people are hearing. But that message of, I'm going to help you live well, is what you're hearing. Okay, you're welcome to ask me any questions. Very, very common. It's really common because, as I talked about, that lack of insight. So if you don't have insight into something that's wrong, it's somebody else's fault. So we have a tendency to suggest that you would go to the GP yourself and raise your concerns.
By myself?
By yourself. So these
I
are...
can't go with him.
No, and a lot of people will also not thank you for talking about them in front of them. And we never ever want to disempower a person. We never want to point out what they can't do. We want to focus on what they can do. So we will encourage carers to go to the doctor by themselves, to list their concerns, to list their evidence. So these are the things I've noticed. And then ask the doctor for help. That's when that sort of routine phone call comes in. I'm doing some routine health checks. Can you come down and have your blood pressure taken or a blood test or whatever? And as part of that, the doctor can do some investigation without them knowing that it was initiated by you. Does that make sense? Sounds a bit sneaky, but it's much better that way than you drag somebody unwilling and you point out all their deficits in front of them. Yeah, because you've got to look after your brain the same way as you look after your body. So we know that, heart disease did a lot of information around awareness raising about keeping active, eating a good diet, those kind of things. I've got a nice book. Oh, here comes Jane. So it's called Healthy Brain, Healthy Life. You've got to exercise your brain the same way as you exercise your body. So cognitive exercises like crosswords, like Sudoku, like word puzzles, creative activities, so arts and crafts. The biggest one is socializing, so interacting with other people, talking to other people, going out, being involved, coming down here and joining activities, whatever they may be, arty, music, exercise classes. Yeah, so absolutely. Keep doing things. Grief and, particularly the change in lifestyle after like 60 years together is massive. So it would be normal that you would change in the way you think and the way you act. And that is at the forefront of your mind. So yes, it is. I would say that it's worth talking it through with a doctor. But it's also, everybody's memory declines as we get older. And I had a client once who explained it to me beautifully. Or he walked with a stick. He said, I walk with a stick because I've got a gammy knee, and if I don't use my walking stick, I can't walk well. He said, so there's nothing wrong with my wife's knees, but she doesn't think like she used to. But if we could give her a walking stick for the brain, she would function just the same. So we've got a lot of ideas, and I'm happy to talk to you afterwards, about little walking sticks we can put in place for the brain. So that, what can I do so I don't forget, or so I remember what day it is. It doesn't mean that it's dementia. It means there's other things going on, but we can help support it. Does that make sense? Yeah. And I'm really pleased to hear the way you said that. We've both been going, because I've heard too many times people say, oh, yeah, well, my husband goes to a speech pathologist for an hour a week, but it's not changing. Well, it's not changing because you're not practicing. You're not learning those strategies and using them. So a lot of what we do and a lot of what allied health therapists do is helping a carer learn how to adapt the way they live as well, in order to help the person with the disease. I wish we did, and the only answer I have for that is that there are millions of dollars being spent worldwide to work out what's causing those amyloid plaques to accumulate. Because if we could stop them accumulating, we could stop the disease.
So it's not fluoride or sugar or the food we eat or
so we
how
don't
we
know.
eat it?
No, we don't know what it is.
Why not? What century are we in? How long have we been practicing this probable?
Yeah, great question. But there are people working on it.
About time.
And I do fundamentally believe that one day we will know.
Oh, might be a bit late for me.
I guess, as you were saying, Louise, as Louise was saying right at the beginning, that as we're ageing more due to medical intervention, then there's more of a chance of that happening.
Yeah.
And we are living a lot longer. I think I said last year at the Expo, we had a thing of a time walk here where you could walk along where you were aged. We did it here, and you put yourself in the place where you are now, and then you go back and stand where you think you feel like, you know. And I did some research on that and looked up. My dad used to say a use-by date, but what's the proper word for it? A life expectancy date. I was born in 1953. On that year, I was expected to live until 72. Now, which isn't that far more, it's 85 for women. You know, really, we expect a lot. You know, we expect a lot. So we've got to do, if we're going to live longer, we've got to put the effort into staying well and doing all the things that Louise is telling. Anyway, I'm taking over your...
That's the example that was given earlier, right? Like, we maintain a car, we take a car for a service, so we've got to look after our bodies and our brains as well, because they do have a use-by date. Way too often, people who are living with dementia withdraw socially because they're embarrassed, because they don't think that they can do the things that they used to do, or their carers are embarrassed and they don't want people to see them like that. That's actually the worst thing that can possibly happen. So we want people to stay engaged, and a large part of what we're doing, and Jane is running a session at the Civic Centre on Monday afternoon, is if we can make the community aware and the community more accepting, people won't withdraw and they will have a better quality of life.
Thank you. So we all need to join CNC.
That's right. That's right.
Louise, is Jane going to speak about what she's doing on Monday night, or are you going to speak about that?
Do you want? Okay, so we are here until Tuesday. On Monday morning, I'm running a session here which focuses on changes in behaviour. So why a person living with dementia's behaviour changes, what strategies we can put in place to cope with those changes of behaviour and to make their life and a carer's life better. So that's Monday morning. Monday afternoon, 5:30 at the Civic Centre, Jane is running a session called It Starts With You. So that's about how everybody's awareness can be built into what dementia is, what challenges a person living with dementia faces, and how as a community we can wrap our arms around them and then we can make life easier. And then on Tuesday morning, I'm running here a session called Activities at Home, which looks at activities that a person with dementia can do, how activities can be modified so that a person is not withdrawing, is not sitting in a chair looking at a blank wall, but is living a purposeful and meaningful life. And although it's called Activities at Home, it's actually activities in general. So we know, we've talked about that apathy, that lack of motivation. So this is how we can combat those. We're also here all day tomorrow. If anybody would like to meet us, one-to-one, just discuss anything, any questions about dementia or supports or services. An activity is anything we do. So yes, it can be puzzles, it can be exercise, it can be learning a new hobby, it can be doing the household chores, it can be baking, it can be cooking, it can be dressing, all those things. Okay. So my mum always told me that fish was brain food.
Yeah.
I don't know if that's true or if that was just to get me to eat fish. Well, the phrase we use is anything that's good for the heart is good for the brain. So we know that a heart-healthy diet, so a reduction in saturated fats predominantly, is good for the brain because it's keeping that flow of oxygenated blood. I'm not a nutritionist. I'm not a doctor. I firmly believe that everything in moderation is the phrase my grandma used to use. I don't think there's a lot of benefit in denying yourself anything. Excess alcohol is not good for you. Excess sugar is not good for you. Excess fat is not good for you. But a little bit is all right. Does that answer your question?
Thank you, Louise.
Okay, thank you.
Very much.